Hello, everyone, and a warm welcome to today's edition of Pathcast. Today is Tuesday, May 28, 2024. I'm Rifat Manan in California. Today, we are very delighted to welcome Dr. Ashish Chandra, who is a consultant cytopathologist at Guy's and St. Thomas NHS Foundation in the United Kingdom. And he's a very renowned cytopathologist. And currently he works as the lead consultant cytopathologist there, and he also practices uropathology, and he has many laurels. Like he currently serves as the chairman of the British Association of Urologic Pathologists. He is also the vice president of International Academy of Cytology. He's the deputy editor of Cytopathology, and we are very delighted and honored to have Dr. Chandra with us today. And he is going to give us a talk on serous fluid cytology, the international system for reporting it. And you can always reach out to Dr. Chandra on Twitter. You can see his Twitter handle there. And thank you so much, Dr. Chandra, for joining us today. And for our viewers, as always, please feel free to post your questions and comments on our Facebook and YouTube chat windows. We will pass them on to Dr. Chandra at the end of the lecture. And thank you so much again, Dr. Chandra, for joining us. Over to you now.
Thank you very much, Dr. Manan, for the kind invitation to Pathcast. This is probably the first time I find myself live on Facebook and on YouTube at the same time. So I will just switch off my video momentarily now so that we can focus on what I have to say. And I am based at Guy's and St. Thomas's Hospital, which is in the centre of London, as you can see, with the Houses of Parliament and the Big Ben just across the lawns. And my office is sort of at the top left corner of this screen, which is not here within this picture. But this is a beautiful day in spring. Unfortunately, today is a bit grey and cloudy, which is far more typical of English weather. But it is absolutely joyous to be talking to you 5 o'clock in the afternoon, my time, but I know you're all attending this at different times of the day from where you're based. So it is my great pleasure to introduce you to the international system for reporting serous fluid cytopathology. Some of you might already be familiar with it, but I'm assuming that either you aren't familiar with it yet or haven't started using it, or if you are using it, I would love to get your feedback, and perhaps you can continue to post your comments and questions in the chat box, which then I will address at the end of my presentation. So before we really launch into serous fluid cytopathology, just a word to say why we need standardized reporting terminologies. In the last few years, we have seen a flurry of, a very site-specific or organ-specific or tumor-specific terminologies across all sites in the body in cytopathology. And of course, they've existed as reporting systems in histopathology as well through various WHO classifications. And this is the same principle why we need the same sort of language across histopathology and cytopathology so that we can communicate better between ourselves as pathologists, whether we are cytopathologists or both, but also more importantly, to convey what we mean and to mean what we say in our reports to clinicians so that they can in turn relay our message and our interpretation of the findings to the patients, which will help guide their clinical management. It also serves to be able to compare data nationally and internationally and to share knowledge such as risk of malignancy for various diagnostic categories and also for forming the evidence base for making any clinical guidelines or recommendations. Now, the confusing bit is that you could have multiple terminology systems for the same specimen type. And then, it can be a question of, which one do I choose? Should I follow the one that my department or my institution uses? Should I follow the one that, say, my national pathology or cytology society recommends, or should I use the one which is recommended internationally? And the decision to do that really relies on you making that choice by examining all of these systems and saying, are they all saying the same thing? How different are they? And is this data validated? Is it being updated based on emerging evidence? And so, you could be using one classification or the other, or even more than one, depending on what your clinicians are most comfortable with. And of course, like the WHO and TNM classifications, all terminology systems are also fluid. So, with that introduction, I wonder if some of you have managed to get hold of a copy for your department or a personal copy of the International System for Serous Fluid Cytopathology. This was published at the end of 2020, and in fact, we will soon be starting work on the second edition. And the reason why we needed this was to be able to answer some very practical clinical questions. And following on from the Paris system for reporting urinary tract cytopathology, where the authors and editors had done some really groundbreaking work to evaluate the evidence of adequacy in urine samples, and we wanted to do the same for serous fluid samples to be able to offer some clinical advice in terms of what is an optimal volume to send to the cytology laboratory and what types of cells make up an effusion. And this would in turn help define what a true negative sample is. That is to say, when we say there's no malignant cells in the sample, the patient is actually free of metastatic disease in their body cavity specimens. There were also other issues such as the overlapping use of the atypia and suspicious categories. These two categories are a problem across all terminology systems, particularly atypia. And we very much wanted to have a diagnostic terminology system which might be atypia free. But when we did our survey and asked our colleagues about whether they wanted to see a terminology system which simply didn't have an atypical category, they said, well, hold on for now, because we do use atypia in special circumstances in serous fluid cytopathology. And so maybe we need to try and make a distinction between atypia and suspicious based on cytological features. And so we went along to retain the atypia category in this terminology system. We also wanted to take the time to evaluate the position of cytology in reporting mesothelioma. So the gold standard for the diagnosis of mesothelioma, of course, is still a pleural biopsy, where you need to demonstrate invasion into the subpleural connective tissue and fat to diagnose malignant mesothelioma. But given the molecular and immunohistochemical diagnosis of mesothelioma in this day and age, there is no reason why you can't use a cytology sample to be able to reach the diagnostic threshold. And this is really valuable when the patient's perhaps too unwell to have a pleural biopsy, and there is, an adequate amount of fluid and a good cell block to be able to do all the ancillary workup you need to be able to make a confident diagnosis of mesothelioma. And then last but not the least, we wanted to address the issue of peritoneal washings, and in particular, how to tackle this thorny issue of reporting the presence of epithelial cells in peritoneal washing specimens. So what this terminology system has done in the last couple of years, in the last 3 years that it's been around, is that it has promoted a lot of audit and research, which has generated many publications and presentations internationally. And you can see that people have really, tested the system. They haven't sort of passively accepted whatever it is we are proposing, but they have put it to the test and they've shared their results and findings. And these continue to be published and presented. And I very much look forward to the forthcoming meetings, the European Congress in Germany at the end of June, and then also hopefully at the American Society of Cytopathology meeting in November in Orlando, where I would love to see and hear about your experience of using this system. As far as the system itself goes, it's a very easy and intuitive system to use. It is very much along the same lines of the pre-existing terminology systems for urine or thyroid or salivary gland, and it consists of a non-diagnostic category, negative for malignancy, atypia of undetermined significance or AUS, suspicious for malignancy, and then the malignant category, which is split into primary, mainly to cover mesotheliomas, and secondary to cover not just metastatic carcinomas, but also secondary involvement by leukemias and lymphomas, and also non-carcinomatous malignancies such as melanomas and sarcomas. So that's why the terminology is, primary and secondary, and not primary and metastatic. And as I say, we will take these categories up one by one and look at some examples of these. So what are the factors involved in the adequacy of serous fluid samples? And broadly speaking, these are three factors. There's the sample volume, there is the cell content of the specimen, and there is the cellular preservation. In terms of the sample volume, the key question to answer, rather like in the Paris system, was whether there was a recommended sample or volume that we could suggest to our clinical users. And we owe our thanks to Johns Hopkins and other institutions that subsequently validated and have revalidated 75 ml as the optimal volume for cytological assessment of pleural fluids and peritoneal and acidic fluid samples, whereas the same group, again, Dr. Rupert et al. From Hopkins, later demonstrated that even 60 ml was sufficient for pericardial fluid. Now, this is not to say that smaller volume samples should be rejected, but we have to process whatever we receive, and even if it's a 5 or a 10 ml sample, we should process and report upon it. But with the sort of caveat at the end to say no malignant cells seen, but the recommended volume for fluid samples is 75 ml for pleural and acidic fluid, or 60 ml for pericardial fluid. So based on low volume samples, I think it becomes really important to also educate our clinical colleagues as we go along to say that we've processed this sample and it's negative, but in order to really be confident, we probably need a larger volume of sample. Another message to our clinical colleagues is to really divide the specimen at the time of collection so that we are sent the optimal volume of, say, 75 ml, and then they can send off parts of the sample, from, say, a liter of fluid that they might have collected, also to biochemistry and microbiology, but they should do that in parallel rather than sending all of the sample to cytology and then us sending samples secondhand onto microbiology and biochemistry, because as time goes by, the samples deteriorate and they become not only poor value for cytology, but also for biochemical and microbiological investigations. So those are my comments about sample volume and the message to clinicians. In terms of cell content, the big question to answer was whether you have to see mesothelial cells in serous fluid samples. And the short answer to that is no, you don't, because it is completely acceptable to find only lymphocytes in, say, tuberculous or chylous effusions, or only neutrophils in an empyema associated with, say, an acute bacterial infection. So you could have benign effusions without mesothelial cells. And conversely, you could have a sample which is just made up exclusively of malignant cells, a single cell population of, say, signatoring cells for a metastatic gastric adenocarcinoma. And again, you don't need to see mesothelial cells there to, for adequacy evaluation, because the specimen is diagnostic even in the absence of mesothelial cells. Having said that, it is nice to see them when they're there, particularly if the sample is small volume and hemorrhagic and doesn't really have much diagnostic material. But if you see mesothelial cells, there's at least some confidence that that a body cavity has been sampled and that the sample isn't just blood. alone. And last but not the least, cellular preservation, which to my mind is probably the most important out of these, because you could have a sample which is adequate in terms of volume and cell content, but if it is poorly preserved, either because of loss of quality due to degenerative changes, because of delay in transportation to the laboratory, resulting in bacterial overgrowth, or if there are technical artifacts and contaminants present, then in spite of a good cellular specimen, you could have difficulty in interpreting it. And we're used to dealing with this scenario with the FNA samples, but this is also true of liquid samples. So again, all of these recommendations have resulted in research and publications that have either tested or even challenged these recommendations. People have looked at the impact of using cell blocks and ancillary tests, and people have also suggested different volumes in their practice to say, we find that we are able to make reliable diagnoses on smaller volumes of sample. But I must reiterate that the original studies done had really taken into account, thousands of specimens over a very long period of time. So, it was really based on some very high volume studies. Okay, so just to familiarize you with the system, I will go through 6 cases with you, and you can, jot down your questions. You can start typing them in, but I will take them up at the end. So the first case here is that of a 54-year-old male with a left-sided pleural effusion, presenting with, cough and chest pain for 1 week. The patient is a smoker. And macroscopically, we have received only 2 ml of heavily blood-stained fluid, from which 1 thin prep, PAP, and 1 DipQuick Giemsa cytospin has been prepared. And I'll take a moment here to talk to you a little bit about the cytopreparatory aspects of serous effusion samples, because as we said, 2 ml falls way short of the 75 ml that we would have liked to have received, but we would have to process this sample. And I would ask all trainees and young pathologists tuned in today to, just turn the page over on your request form, if you receive paper request forms, to just see what the macroscopic findings of a fluid sample are. Because our cytotechnologist colleagues have, taken the time to measure the volume of the specimen and to describe the appearances of the specimen, and all of that has meaning. So, if it's straw-colored fluid, it could imply that it's a transudate. If it is milky, it might suggest that it's chylous effusion. If it is purulent, it implies that it's an empyema. So, do take a moment to pay attention to the macroscopic volume and description of the fluid specimen. In terms of preparation, a combination of a PAP and Giemsa is recommended. This PAP could either be a cytospin or it could be a liquid-based preparation, such as either thin prep or SurePath. And then your Giemsa preparation, which of course can't be a thin prep or a SurePath, could just be a direct spread, or it could be a Romanovsky dye-based stain would either be DipQuick or Hemacolor or MGG. Oh, sorry, shot from ahead by a few slides. Oh dear, really? Oh my goodness, gone a bit. Let me slow down. So, in the FRCPath college guidelines, we have recommended in our tissue pathways for diagnostic cytopathology document that serous fluid samples should be examined as a combination of a PAP and Giemsa preparation. And if they are accompanied by a stainless clot present within the fluid sample, that should be processed automatically. A cell block may be requested by the pathologist if they feel the need to do any ancillary tests if there isn't a spontaneous clot present. But for most specimens, just the routine stains, PAP and Giemsa are adequate. If a clot is present, it should be processed, and a cell block need only be requested if there is no spontaneous clot, and ancillary testing is required. Of course, you can do your ancillary workup on cytospins or thin preps as well, but many laboratories have validated their immunostaining and genetic testing on cell blocks on formalin fixed paraffin embedded material, and so they tend to follow the same protocols. And again, the minimum recommendations for sample preparation and staining taken from the FRCPath for serous effusions recommends a combination of a PAP and a Giemsa, whereas for other exfoliative cytology specimens such as bronchial and bronchoalveolar lavage and urine, only a PAP stain is recommended. With all other specimen types, we recommend a combination, again, of PAP and Giemsa. So you don't even need to put this slide under the microscope to know that you're going to expect to see only lysed red blood cells in this thin prep from this very hemorrhagic small volume sample. And these are all lysed blood cells seen on the thin prep PAP. There are no mesothelial cells or any white blood cells. On Giemsa stain, on the other hand, you might see both the red and white blood cells. And again, bear in mind not to refer to these as inflammatory cells, because that indicates that you're saying that there is an inflammatory process going on. And if you don't think that the number of inflammatory cells is markedly increased, then you should probably call it a blood stain sample, or that the smears consist of red and white blood cells only, and not refer to these white blood cells as inflammatory cells. So the sample report, as for all other reporting terminologies, should have an adequacy statement, a diagnostic category, and in selected cases, perhaps a clinical comment may be necessary. And so a report for this case would read something like evaluation limited by heavy blood staining, likely non-representative sample. So this is falls under the diagnostic category, and it gives you a chance to send the feedback to the clinical colleagues to say that a repeat sample with 75 ml volume is requested if that is possible. Let's move on to our second case then, a 64-year-old male with liver cirrhosis and ascites. And macroscopically, we have 60 ml of straw-colored fluid, not quite 75, but at least it's closer to the optimal requirement. And then in this case, 2 cytospins, PAP and Giemsa, were prepared. And here on the Giemsa preparation, you can see the very basophilic mesothelial cells, and they're hanging together in loosely cohesive groups with gaps or windows between them. You can also see these peripheral blebs or protrusions of the cytoplasm. And the cytoplasm itself has this two-tone characteristic staining property. The nuclei tend to be smooth, round and oval, and do not vary much in terms of size and shape, although cells might be binucleated or even multinucleated. And then you can see some submembranous glycogen vacuoles and these peripheral blebs, as I said, which correspond to the ultrastructure of the microvilli that are present on the surface of these mesothelial cells. And within these mesothelial cell groups, you can see infiltration by neutrophils and lymphocytes interacting with these mesothelial cells. So it really does look like the number of inflammatory cells is increased in this particular sample. And again, on the PAP, you are able to appreciate the chromatin structure much better. And you can see that the chromatin is very finely, evenly dispersed with only either multiple small nucleoli, but no single large eosinophilic nucleoli. And again, the gaps or windows and small numbers of inflammatory cells, which are associated with these mesothelial cell groups. So again, your sample report will include all of the following subsections: that this is satisfactory for evaluation. It contains neutrophils, mesothelial cells, and a few lymphocytes, and this would fall in the negative for malignancy category. And given the history of cirrhosis and the high proportion of neutrophils, you could say that this may represent spontaneous bacterial peritonitis. and ask for clinical correlation. So the negative for malignancy category, you might expect to see just the normal populations that you can see in an effusion. An effusion, of course, is always pathological. It might be benign or malignant, but it's not a normal finding. Normally, you just have a very small quantity of fluid, especially between the visceral and parietal pleura, just for keeping the smooth movement, expansion and contraction of the lungs. And it's only when the fluid increases in amount that it's referred to as an effusion. And reactive effusions or non-malignant effusions may contain variable proportions of different inflammatory cells. But based on the proportion of those inflammatory cells, you could get some or predict some specific causes. If it is lymphocyte rich or eosinophil rich, you could, for instance, if it's eosinophil rich, suggest that this may be due to either recent pleural fluid aspiration, or it might be associated with allergic conditions. Lymphocytic effusions are most commonly associated with viral infections, chest infections, but also tuberculosis and other types of chronic infections. Whereas a neutrophilic effusion or an empyema is usually indicative of bacterial infection, but occasionally they may also be associated with, say, a squamous cell carcinoma rupturing into the pleural cavity, but that is a much more rare clinical circumstance. And here you would be looking hard to look for any malignant squamous cells in the background of these neutrophils. Okay, so moving on to our third category now is the history of a 46-year-old female with a history of breast carcinoma 6 years ago, now presenting with cough and a small pleural effusion. Macroscopically, we've received a smaller than optimal sample of 20 ml, from which a pair of cytospins have been prepared. And on the GEMSA, we see at a higher magnification, lots of cells where perhaps you will recognize these as mesothelial cells, the ones with the deep blue cytoplasm, the gaps and windows, the binucleation perhaps. And then given that they seem to be almost in continuity with these cells here, which do not have that same two-tone basophilic cytoplasm, but they are microvacuolated, the nuclei look still very similar to those of the mesothelial cells. But there are also some eosinophils present in this sample. So has there been a recent pleural effusion, pleural tap from this patient? And given that there is a history of breast carcinoma, you want to be really sure that you're not dealing with small numbers of monotonous malignant cell population from a breast adenocarcinoma. And then on the thin prep PAP, again, you see these cells which you think are probably mesothelial cells, but some of them do have quite prominent nucleoli. And although some of them are binucleate and others have multiple small nucleoli, and although you think these are probably just mesothelial cells, but in the clinical context of previous breast carcinoma, you're a little bit uncertain. And so the presence of these occasional poorly preserved cells with a little bit of nuclear enlargement, hyperchromasia, but no obvious chromatin or nuclear membrane abnormalities may result in you being a bit uncertain about the nature of these cells. You favor the fact that these are likely degenerated macrophage mesothelial cells, but you want to exclude the presence of small numbers of bland epithelial cells, which would be important in the case of someone with a history of breast carcinoma. And so in these cases, if there is a clot, of course, it should be spontaneously processed by the laboratory. If not, I would certainly request for a cell block to be made, and I would do just a small panel of 2 epithelial and 2 mesothelial markers to exclude the possibility of metastatic carcinoma here. And then if I'm satisfied that these epithelial markers are negative, I can sign the case out as negative, feeling reassured that those degenerate atypical cells that I saw were probably just degenerate mesothelial cells. So on the cell block in this case, again, we just have lots of mesothelial cells, some macrophages and some fibrin, a few scattered lymphocytes, but no epithelial cells. And the BER EP4 and GATA3 markers looking for epithelial cells are also negative. So the atypia category is actually a very uncommonly used category in effusions. Many experienced cytologists don't like to use it, and they'd much rather use suspicious category or just call them negative based on their experience. And as I said, we very much wanted to exclude this category completely, but I'm not sure that we can just. And so, guided by our survey respondents, and I hope you've had that you responded to the survey that was sent out by the ASC a couple of months ago, and then I think you may have had a reminder email from the ASC and the ISC to please submit your feedback to the international system and tell us what you would like to see in the second edition, what we can explain and do better in the next iteration of the book. And so what we found in the survey was that a lot of the users and reporting pathologists across the world had been using a sort of a mental two-step process of, a preliminary diagnosis, and obviously some of them were, sending out a report at this point, and then a second final report with the results of the immunostains. Now, I'm not saying that you should all do this, but this is what practice seemed to indicate, that when you have small numbers of atypical cells, you're uncertain about their nature, you put that case aside, you call it atypical, you order some immunochemistry, and if that demonstrates these atypical cells to be macrophages or mesothelial cells, you sign it out as negative. If, on the other hand, the immunochemistry demonstrates these to be epithelial, which may happen in 10 to 20% cases, then your final report could be upgraded from atypical to either suspicious or even a confident malignant secondary. And then you will actually only be left with a very small number of cases where there are insufficient number of representative cells, or the immunochemistry is either technically equivocal or difficult to interpret, and where your final report would still be atypia, and you would end up asking for a repeat sample. So again, this has been tested and challenged in literature in the last few years, and authors have actually published and shared their results to say how many or what proportion of their cases were atypical and what the outcomes were. And again, it's a very good material for auditing and publishing. So I would encourage you all to also audit your own laboratory results. There are also systematic reviews that have been published, and some more up-to-date ones are being also written up, and your articles and submissions would very much be counted for if you submit your published data. Okay, so case 4 out of a total of 6, so we're halfway through, is a 68-year-old man with pleural fluid with a history of lung carcinoma, and macroscopically we've received 30 ml of blood-tinged fluid. And here on the cytospin PAP, you can see that there are 2 cells which appear much larger than the surrounding lymphocytes and macrophages and mesothelial cells. When you look at these cells more closely, again, their nuclei also look a little bit big. And then when you see the Giemsa, you begin to see small groups of 2 or 3 cells, which are again much, much larger compared to the surrounding lymphocytes, macrophages, and mesothelial cells, and their nuclei are seen to be relatively abnormal and large. And so based on these 5 or 6 cells, you are suspicious that these cells are probably epithelial in nature, but they are too few to be absolutely confident on based on morphology alone. And so you may want to request a cell block if there isn't a clot section already available, and perhaps just want to do a small panel of immunostains to confirm your suspicion that these small groups of cells are indeed epithelial in type, and therefore this is a malignant effusion with small numbers of malignant epithelial cells. So this is a bit of a number game. If you only have small numbers of cells or groups with nuclear pleomorphism, where you believe that, if I just had 10 more of these same exact cells, I would feel a lot more comfortable and confident just signing it out as malignant. But because the number is very small or they're showing degenerative changes, you want to hold back and perhaps perform a small panel of immunostains to confirm your suspicions. This may also happen sometimes with cells with bland appearances or only mild pleomorphism, where you might only use the atypical category. But if the index of suspicion is high, you may also end up using the suspicious category for these cases with cells with bland appearances, but slightly larger number of these mildly pleomorphic cells. You could also use the suspicious category if in an acidic fluid you see mucinous material with relatively few or no epithelial cells. And so you're suspecting pseudomyxoma. And there again, you could call the acidic fluid suspicious for malignancy and perhaps go on to do a cell block and some epithelial immunostains to confirm your suspicions. And also for lymphocytic effusions where you have a monotonous cell population, but you would like to confirm your suspicion by either doing flow cytometry or making a cell block and doing a panel of immunostains to characterize your lymphoid population. So similar to the algorithm for atypia, for the suspicious category, again, it's more of a number game, a quantitative factor, where you have small numbers of cells in which you strongly suspect are malignant, but you want to put that case aside, and at which point you may want to issue just a preliminary report if you're coming up to a weekend or a long bank holiday or public holiday, where you think, well, let me put something on the system so that if the patient deteriorates over the weekend, the clinician at least has some idea of what you think, and then you will come back after the holiday and hopefully get the results of your immunochemistry back, which if it confirms malignancy, you could issue a final definitive report of malignant secondary and go on to do your immunostains to ascertain the primary site. And so you would actually only be left with a very small number of cases where either the number of cells remains very small or absent on the cell block, or the immunochemistry hasn't worked, where you might need another sample to be able to confirm your suspicions. This can be very important in the ancillary testing of lung adenocarcinoma, where the oncologists are already aware of the fact that the patient has a lung cancer, and the reason why they're repeating the effusion is not for a diagnosis, but for you to do the molecular marking, markers on the effusion sample, and it could just be a small panel of ALK-ROS, PD-L1, or just EGFR. And in case of, say, breast cancer, it could just be for HER2 and ER receptors. And so the message here is, don't do very big panels straight away in the first instance, particularly when you have small numbers of malignant cells in a cell block. Restrict the use of IHC just like you would an EBUS sample. To start with, just a TTF1 and P40 perhaps, maybe in absent A, so that if you are able to prove that it is lung adenocarcinoma, then you've got material remaining to do the more important markers that the oncologist is really after. And so in this regard, there have been publications again to show that you only need a small number of cells to be able to carry out ancillary investigations. So you want to treat every cell block with respect to be able to conserve the number of cells to be able to do the most relevant ancillary findings, not a general panel with CK7, CK20, and a very generic panel. This is not carcinoma of unknown origin. This is a known lung adenocarcinoma, and the specific question there is to do the genetics. So just to summarize the differences and similarities between the atypical and suspicious categories, which is the reason for us actually conserving these two categories in this terminology system. And so in the atypical category, the cytological atypia is only mild, with a little bit of nuclear enlargement and hyperchromasia, usually in a small number of dispersed cells or occasional small groups, where a benign cell type such as mesothelial cells or macrophages is favored. And so you would anticipate that the outcome on immunochemistry would be benign, and the risk of malignancy, which is suggested in this category, should be to the tune of about 20%. In sharp contrast, in the suspicious for malignant category, we would really expect the risk of malignancy to be much higher, around 80%, because here you have got small numbers of cells which really look like they probably are malignant cells. And if you just had a few more of those, you would feel a lot more confident in signing it out. And so, you're favoring an epithelial lineage, and you do your immunochemistry for confirmation of malignancy rather than exclusion of malignancy. So those, broadly speaking, are the differences between the atypical and suspicious categories, but hopefully with a good degree of separation of the risk of malignancy to justify the two categories. Okay, down to our last couple of cases before taking some questions. Case number 5 is that of a 68-year-old man with a history of occupational exposure to asbestos. And this is a large unilateral hemorrhagic pleural effusion from which we've received 80 ml of blood-stained fluid, which contained a clot that was processed, and then a pair of cytospins, MGG and PAP, were prepared. And here is the problem, I'm sure you would anticipate just from that history, about mesothelial cells. Because whilst mesothelial cells can be separated from epithelial cells with ease because of their very special appearances of the two-tone staining of the cytoplasm with their peripheral blebs, their submembranous glycogen vacuoles, relatively bland appearance of the nuclei, by looking at a mesothelial cell in isolation, you can't really say whether it's benign or malignant. So you have to be guided by the appearances across the specimen, but most importantly, also by performing the immunostains and correlation with the radiological and clinical findings. So in a supercellular specimen like this, with these equal-sized morules or clusters of mesothelial cells with a relatively monotonous appearance of the nuclei, but with prominent nucleoli, but with the preserved gaps and windows between them, we know this is an issue of a mesothelial proliferation. And suspicious for a mesothelioma rather than a metastatic adenocarcinoma. And these features are also reflected in the clot section on the H&E stain, where again you can see these groups of mesothelial cells with gaps or windows, really big cherry red single nucleoli, in a background with macrophages, lymphocytes, but no epithelial cells. So really in this day and age, you are really expected to be able to perform a very basic panel of ancillary tests on mesothelial proliferations. Excuse me. And even using very easily available antibodies like desmin and epithelial membrane antigen, you may be able to demonstrate the preservation of cytoplasmic desmin in reactive mesothelial cells, whereas this is lost in mesothelioma. In epithelial membrane antigen, you would expect to see a strong band-like membranous positive staining in mesothelioma, but not in reactive mesothelial cells. But of course, really what you do need is a BAP1 immunostain, which would be retained within the nuclei of reactive mesothelial cells and is lost in up to 80 to 90% of mesotheliomas. And then if you have access to FISH for either MTAP or P16, then to demonstrate deletion by either of these, is diagnostic and also has some prognostic value in the mesothelioma. So this is what you have to aim to work with. And you can perform these tests even on a cell block or a clot section. Um, so, these tests don't necessarily need to be performed on a biopsy. But if you also receive the biopsy in the department, then it's up to your clinical practice as to whether you choose to do the immunostains on the cytology sample or the biopsy. Chances are you will probably do this on the biopsy, but if the biopsy is non-diagnostic or insufficient for some reason, that at least you can fall back and perform the remaining immunostains or ancillary workup even on your clot section. So it is entirely possible to make a diagnosis of mesothelioma based on ancillary tests performed on a cytology specimen. And this has now, received a lot of attention in the mesothelioma world, where, as I said, the gold standard still remains a pleural biopsy and demonstration of invasion in a pleural biopsy, but it would be entirely acceptable if the diagnosis is based on a cytology sample. So what would reports for a mesothelial proliferation look like? You would describe those small, equal-sized amorular groups and some dispersed mesothelial cells, which are suspicious for mesothelioma based on the morphology alone. You would request your immunostains either on the cell block or clot section or the pleural biopsy. And if then the immunostains using the panel that I described are confirmatory, then you can make a confident, conclusive diagnosis of mesothelioma. Of course, with the rider, that clinical and radiological correlation is always essential. If the morphology is very, suspicious or even classic, but the immunostains are not confirmatory, step back. Don't, in those cases, without the support of the immunostains, call that proliferation a confident mesothelioma. It's best to then call it suspicious for mesothelioma and defer to the biopsy diagnosis and correlation with the imaging and clinical features. And if neither the morphology or the immunostains are confirmatory, it is then best to just stop at an atypical mesothelial proliferation and advise a biopsy or follow-up. So this is how you would approach mesothelial proliferations based on morphology and the panel of immunostains. So the malignant category in the international system requires a recognizable abnormal cell population, which should be present and adequate for robust diagnosis on which clinical management may be based. And this malignant cell type should be specified either on morphology alone or supported by immunochemistry, which results in a splitting of this category into primary, which covers mesothelioma, and secondary, which covers metastatic carcinomas, but also lymphomas and melanomas and other malignancies. The primary organ site would need to be investigated for adenocarcinomas. So, which brings us to our last case, number 6, 45-year-old female with ascites, 35 ml of blood-stained fluid received. And here I'm sure none of you would have any hesitation in recognizing these tightly cohesive groups of unequal size epithelial cells with coarse cytoplasmic vacuolation, nuclear pleomorphism, and on the Giemsa again, you can see that there aren't any gaps or windows between these cells to suggest that this is a mesothelial proliferation, and the nuclei are large, irregular, and they vary from one cell to the next, from one group to the next. And for comparison, here is a group of normal mesothelial cells and some lymphocytes and macrophages in the background to compare the size of these cells and the architecture and morphology of the nuclei to be able to make a confident diagnosis of metastatic adenocarcinoma. Of course, on the cell block, this could further be, substantiated by the presence of glandular structures or signet ring cells, which would, lend further support to your diagnosis. And then you do your immunostain, and then whether this is a TTF1 or CDX2 stain, strong nuclear positivity indicating the primary site. So ascertaining the primary adenocarcinomas is sort of an expanding field with a growing list of antibodies, which then frequently become replaced as new antibodies come out, which are demonstrated to be more sensitive or specific. And as time goes by, you actually end up modifying these panels, introducing some of the new markers and replacing the old ones. So your sample report for a malignant secondary specimen would include a description and then the diagnostic category and the suggestion that immunostains have been requested to ascertain the primary, but gynae and GI tracts are the most likely sites given the patient demographics. So coming to the last couple of slides, and then I'm ready for some questions. The diagnostic categories are linked to specific clinical managements. So the routine diagnosis is usually done on cytospins or liquid-based preparations such as ThinPrep or SurePath, and may include the use of a clot or a cell block, usually stained as an H&E section. If the sample is non-diagnostic, you can ask for a repeat with 75 ml, where possible. If it is reported as a confident negative, which most of our specimens would be, particularly in a community hospital setting, then the patient may be discharged or simply followed up clinically. For the two indeterminate categories of atypia and suspicious, further work would be necessary with ancillary testing and correlation with any biopsy or clinical data as necessary, where you would expect the outcome of the majority of your atypical cases to be proven to be negative following ancillary workup, and for the ones that were called suspicious to perhaps be proven to be malignant following ancillary workup. And then in the confident malignant category, your ancillary testing is really intended to establish the primary site and or to perform prognostic and predictive markers. So I'd like to draw attention to what we have published in the book already, which was a review, a systematic review of serous effusion cytology before the international system was proposed. So this is the situation as it existed before the international system for reporting serous fluid cytopathology was proposed. So this is looking at the data of, the 50 years of performing cytology on serous effusion, so based on, again, large numbers, which showed a lot of room for improvement. The risk of malignancy was almost very similar in the non-diagnostic and negative categories, and we don't want that to be the case. We certainly want smaller numbers of non-diagnostic specimens and also a reduction in the risk of malignancy in these cases. And also we would like to see a reduction with adequate samples with optimal volume and cellularity to have a lower risk of malignancy. We would also like to see a lower risk of malignancy in the atypia category. Part of the reason why this was so high before the international system was because the atypical and suspicious categories were being used almost interchangeably. Just depending on the degree of suspicion, they were either called atypical, which had a lower risk of malignancy, and suspicious, which had an acceptable 80% or over risk of malignancy. But the performance of pathologists has been consistently high in the malignant category, even before this terminology system was proposed. So I hope going forward, we will be able to revisit this data to improve upon this data following the application of the international system. And I very much look forward to hearing and reading about your institutional data and results and experience. Here are some references at the end, and a huge thank you for your attention. And I'm now going to stop sharing my screen. And oops, what's happened? And show. And hopefully you will see me in a moment. What do I do? Resume.
Yeah, that's great.
All right, I'm back.
Thank you so much, Dr. Chandra. Thanks a lot.
My pleasure.
Thank you. Can you see the questions in the chat
Yes,
box?
I can. I'm just
Great.
going to open up the chat box, and I'm going to start at the top. Presence of mucin without atypical cells in which category? So if you're seeing mucin in acidic fluid samples, and you think this may be related to perhaps a pseudomyxoma due to either an appendiceal or an ovarian mucinous tumor that has ruptured, you should really put it in the suspicious category, because you are warning against a more likely malignant scenario. You could also get mucin perhaps from, say, the rupture of a benign mucinous cyst adenoma, but that is less like clinically uh, uh, compared to the suspicion of a malignant condition like a mucinous cyst adenocarcinoma. So probably better to use the suspicious category, but of course you've got to hunt for the epithelial cells, and by doing a cell block and immunostains to demonstrate any potential source of those mucinous material. What are the recommended preservatives we can use if there is a delay in transportation to the laboratory? So depending on how you process your specimens, it could either be transported just in an equal volume of 95% ethanol, or if you use liquid-based cytology, then it could be transported in Cytolite for thin prep or Cyto-Rich Red for SurePath. If these are not available off-site at the point where these samples are being collected, then yes, you could recommend fixation in equal volume of ethanol. Next question, what is your take on fish and mesothelioma? In which cases do you go for it? So fish is really undertaken, I would say, for cases where you really have maybe equivocal findings with the immunochemistry, with the desmin and epithelial membrane antigens, which are good, easily available markers, but they aren't the most sensitive or specific. Also, perhaps where your BAP1 has come back negative, because bear in mind, not all mesotheliomas will show loss of BAP1 staining. So the 10 to 20% max mesotheliomas which do not show loss of BAP1, you would need fish. So if there is a strong clinical suspicion and your ancillary workup doesn't quite add up, is where you would consider doing fish. How do we calculate risk of malignancy, as not all specimens have tissue follow-up? Absolutely right. So the risk of malignancy, of course, would have to be distinguished between cases for which there is histological follow-up, but a lot of it may just depend on clinical follow-up or surrogate follow-up in terms of clinical progression of disease, or disease-free period. So you'd have to take into account when you publish your data as to how you've calculated it. As long as you've stated how you've done it, that is okay. Of course, having the tissue follow-up is great, particularly for things like mesothelioma, but it's not always possible to do that. Is there any chance of mesothelial proliferation in a patient with metastatic synovial sarcoma? Yes, there could. And hopefully you would be able to demonstrate that the mesothelial proliferation there is, not malignant. It is not showing BAP1 loss. It's showing preservation of cytoplasmic desmin and epithelial membrane antigen outline. And of course, you would also need to demonstrate your finding of synovial sarcoma, ideally on pleural biopsy, which is how I think you would probably be making the diagnosis anyway. Can we go for the international system in cases of synovial fluid aspirates? It's a great question. We're looking to expand the application of the international system to, say, cerebrospinal fluid specimens, which are effusions. And so, we would love to hear your feedback through the survey to tell us whether you would like the terminology system to be extended to its use in CSF and synovial fluid. I don't see why not. Of course, by and large, synovial fluid cytology is negative and related to inflammatory pathologies because malignancy involving articular cartilage and spreading across the articular cartilage into synovial cavities is really vanishingly rare. So it's not frequent to see positive involvement of synovial fluids. But in principle, I completely agree with you. There's no reason why it cannot be applied to CSF or synovial fluid aspirates. And we'll see presentations to this effect in the forthcoming cytology meetings. What fixative is used for blood clot? Formalin. So if there is a blood clot, you would, you would just add formalin to it. If there isn't a blood clot, you can induce a blood clot by adding thrombin or other agents, and then subsequently suspend the cell pellet in formalin and then process it like a mini biopsy. Any prognostic marker then can be done for mesothelioma? Well, FISH for P16 deletion and MTAP have been described, so there is some literature out there for you to review. So in that regard, the FISH test for P16 deletion can serve both as a diagnostic as well as prognostic marker, together with MTAP and CDKN2A deletions. How do you prepare cell block from serous fluid? I never get good cell block. This is a whole talk in its own respect, perhaps given by some expert cytotechnologists, because you can make cell blocks in a variety of ways. And you really do need something that works in your laboratory. Maybe your thrombin is out of date if you're not getting a good cell block. Maybe you could use an alternative method using agar gels or Celient cell blocks, which are commercially available. There are lots of ways you can prepare cell blocks, and that's a whole talk in its own right in cytopathology. But the sample does have to be cellular to start with. So, if it isn't a very cellular specimen, then you may not get a good cell block. So don't worry if you don't get very cellular cell blocks. It's possible that the sample isn't very cellular to start with. What are the technical steps that you use in cell block preparation? So it seems cell blocks are quite an important point of discussion based on this talk, as I expected. And I think you probably need to attend a full talk on the use of cell blocks. So our technical steps involve the addition of thrombin, which must not be out of date. So you have to check the bottle and make sure, otherwise you get spurious false positive staining with different proteins. But basically you induce a clot by adding thrombin, and then you add formalin and you suspend that cell pellet in formalin and then process it like a tiny biopsy. Can we depend on cell block IHC for treatment results like PDL1? It depends on whether you have validated it on sufficient numbers of cases in your laboratory. It is not a frequent ask, certainly on cell blocks for effusion samples. It is validated at other sites, including on lung EBA specimens or head and neck FNA specimens. However, you do need to have demonstrated that you've validated that particular clone of PDL1. Otherwise, you might be better off just relying on the biopsy to perform the PDL1. Rakesh, hi. With 60 to 75 ml of fluid for sample adequacy or even more volume sample received, how do you recommend processing the sample? Another great question. How many tubes to be spun for best cellular yield? Should we preserve some sample for cell block? It's a great question. How do you, transfer a liter of fluid onto a slide? And for that, the key thing is that the sample should be homogenized. So, when you receive a large volume or a bucket which is, fluid, make sure that, the lab gives it a nice, good swirl so that all the cells are, swimming in the suspension and are there uniformly within that sample, so that even if you took a 75 ml volume sample off the top, it would be representative of the sample throughout, not in a sample where all the cells have settled down to the bottom. If the cells have settled down to the bottom, yes, of course, you could use those for making a cell block, because you're likely to get a good sediment from there. But otherwise, just good agitation of the sample to suspend the cells would give you good cellularity in your cytospins. And there is no need to process anything more than um, one tube for your PAP and Giemsa stains. If there is sufficient material that you can put in one tube to get 2 cellular cytospins, that is good enough. You don't need to use, multiple tubes to sample the effusion, especially if it's large volume. What's the best suggested panel to differentiate between adeno and mesothelioma? So great question again. As I said in my talk, to start with, you should just do a small panel of 2 epithelial and mesothelial markers. The epithelial markers could be BER-EP4, MOC31, or something much more sensitive and specific like Claudin-4, whatever works well in your laboratory. And so 2 of those and 2 mesothelial markers like a WT1 and perhaps a BAP1. So if you've done those 2 to start with, then whether you're dealing with an epithelial malignancy or a mesothelioma. If your mesothelial markers, the WT1 comes out positive and BAP1 is lost, then you can go on to do your Desmin and EMA and P16 deletion by FISH if you have access to it. And if your epithelial markers turn out to be positive, then you can go on to do your site-specific markers. But as the first step, it's probably sensible simply just to do 2 epithelial and 2 mesothelial markers. Are the conventional criteria of 3 repeat necessary for exclusion of malignancy? No, it's not. This is exactly why you need a good sample to start with. If you've got a good volume, 75 ml plus sample volume to hand, and you've got good quality preparations, then you don't need 3 samples. In fact, we do not recommend that. It's a traumatic procedure. It's not like repeating, a sputum or a urine sample. Even those, for urines, we don't recommend multiple tests as long as the sample is adequate. So one of the things that the international systems have done in terms of adequacy and cellularity is advocating the right volume, which will ensure that you have a good sample to start with, and then you don't need multiple samples. If pleural fluid examination doesn't reveal malignancy, then which one would you give more preference, pleural biopsy or thoracoscopy? So it depends very much on what the clinical question is and what is safe to perform in the patient. A pleural biopsy would, of course, be preferable. It depends on what the clinical question is. So, depending on the findings on the imaging this would probably be a decision that is made by your respiratory physician and surgeon. But you have to be clear whether you are suspecting mesothelioma or a metastatic malignancy. If you're unsure, it would then require a tumor board meeting or a multidisciplinary meeting to have a discussion around what the best step might be in the examination of this patient. Is PD-L1 reliable if the cell count is less than 100 in a cell block section? So it depends on what specimen type you're talking about. Certainly for respiratory samples like EBUS, you do need 100 or 150 samples in a cell block. There are no validated numbers, as far as I'm aware, for serous fluid samples, and maybe there is some literature out there that I need to review. But it just depends on which type of malignancy you're talking about, and whether you're talking about serous effusions or whether you're talking FNA samples from, say, head and neck, or from EBUS from lung. So this is quite a specific question, and will be based on what the clinical question is, which clone you're using, and what is the published data with with reference to the reliability and the validity of doing a PDL1 immunostain on that cell block. AUS may be more used in smaller laboratories without access to immune markers or advanced ancillary techniques. What's your opinion on it in regards of the idea of its removal? Well, as I said, we debated it, whether we should keep this entity. And I think we do need to keep it for the time being, because, as you say, it isn't always easy to be able to call a specimen negative or even suspicious. And in terms of some types of proliferation, say, an equivocal mesothelial proliferation, where there is no clinical information to suggest mesothelioma, and you don't have access to immunostains, then I think it is entirely reasonable, or it might be expected that in those settings, the AUS category will be used, to perhaps a higher rate than in other settings. And the next step there just might be other investigations, not necessarily ancillary stains, but maybe the next step in the diagnostic pathway might have to be a biopsy or further imaging. Great question. Thank you. How many slides should be sufficient? We routinely use 2 GIMS and 2 PAP. Well, my lab only uses 1 GIMS and 1 PAP, and that is what's recommended by the Royal College of Pathologists guidelines. So, provided your sample is considered to be adequate in terms of volume and cellularity and representative, and is of is well preserved, it's not degenerate, then just looking at 1 cytospin each of Giemsa and PAP is sufficient. Or if it's a cellular specimen, you could dilute the thin prep, the cytospin, or you could just do a direct smear from the cell button. That is also completely acceptable. If you're using thin prep, then of course you'd only be able to do a PAP, or if you're using ShowPath, again, you'd only do PAP. In which case, I would suggest that perhaps you should use cell blocks a little bit more, readily, because you are relying on only 1 stain there. And it may be worth considering perhaps using a cell block at a slightly lower threshold of when you suspect malignancy, because you're only really dealing with 1 rather than 2 stains, which are ideal. How do you differentiate between hemorrhagic tap and hemorrhagic effusion? So as I said, in a purely hemorrhagic tap, you usually only get a few mil of sample. It's unlikely you'd get, 50, 60 mil of a traumatic sample, unless it's a patient who is clinically thought to have hemothorax, and the procedure is being done knowing that you're only going to aspirate blood. But otherwise, in a hemorrhagic effusion, you would really expect to see at least some mesothelial cells, or even macrophages or other white blood cells. Otherwise, it can be quite difficult and might require clinical correlation with the reason for doing the tap, and whether clinically it would be acceptable to regard it as hemorrhagic, to repeat it, or whether it's a large volume hemorrhagic effusion like you can get in mesothelioma. All great questions, I have to say. Some of them very new for me as well, and they've really got me thinking, and I need to go and do some reading up as well, based on the questions you've asked. But please do take part in the survey, and tell us what you like and what you don't like about this terminology system, and how we can develop it further going forward. Thank you so much for listening to me today.
Thank you so much,
Thank you, Dr.
Chandra.
Manan.
Thanks a lot. This was a highly educational talk, and as you can see that the viewers have so many questions for you. And
I'm delighted.
thank you so much.
Absolutely thrilled. Thank you.
You have been mentioning about a survey, and I was just wondering that if I missed it, that where do they get the survey link?
So if you go on the American Society of Cytology's website, ASC, it's cytopathology.org, and you will see the survey link there to the International System for Serous Fluid Cytology. It's also there on the IAC website, which I think is cytology-iac.org. So at either of these websites, you should be able to access it. I know we're due to close the survey quite soon because we've already had like a few hundred replies, and we want to start looking at the answers now. But the more the merrier, and I'd be really delighted to receive your responses while there's still some time. Thank you.
Yeah, I just shared the link for the cytology
Super, thank you.
desisc.org website on YouTube link. So if anyone is interested, so please go and then participate in the survey. And as Dr. Chandra mentioned, that he would really appreciate your feedback. And as they're all trying to develop a very robust system for reporting, which can be used all over the world. And Dr. Chandra, you would be happy to hear that we had more than 100 or 200 viewers who joined from so many different countries of the world. I could keep track of some countries that our viewers mentioned. So they joined from places as far as Zambia, Mexico, Colombia, Pakistan, Turkey, Oman, Myanmar, Bangladesh, Tajikistan, Kurdistan, Ethiopia, United Kingdom. A lot of students joined from India, and special thanks to Dr. Asima Das for organizing this lecture, and all the residents at her department, that is Jorhat Medical College, and a lot of residents joined from her department. So thanks to all the residents there for your enthusiasm and interest. And as always, so please feel free to follow us on our different social media platforms. So we are on Facebook, YouTube, Instagram, as well as on X, and you can find us there, and you can scan this QR code where you will be able to follow us there. And our next lecture is also coming up, that is on June 4th, and we will have a talk on digital pathology. So basically on artificial intelligence, and our speaker will be Dr. Adriana Bueno, who is a consultant pathologist in Brazil. So hope you see you at that time. And thank you so much once again, Dr. Chandra. This was an amazing talk. Thanks a lot.
Thank you. It means the world to me to have such a great audience and with so many questions. Thank you very much indeed.
Thank you.